Hello, everyone. I'm Sarah Bolton, your virtual host for the Myasthenia Gravis Association. Today, I'm joined with Catherine Clemens, our Community Program Coordinator. We are so glad you're with us today. If this is your first time joining us and you need a new patient packet or any more information, please visit our website, www.mgakc.org. And following tonight's session, you will be sent a survey, and we'd love your feedback. If you can believe it, this is our last virtual meetup for 2024. It's been a great year, and we will be revealing the 2025 webinar dates soon, so stay tuned. This evening, we have Dr. Evan Glidewell, who is the Assistant Professor of Anesthesiology at the University of Kansas Medical Center, joining us to discuss how to prepare for surgery. Dr. Glidewell, we'll turn it over to you.
Great. Can you still hear me okay?
Yes, thanks.
Perfect. That was a very short announcement, but thank you for the nice introduction. I wasn't sure how many announcements we were going to have. My screen sharing is paused, it says.
Oh, I can see your screen.
Can you see my slides?
I can see Myasthenia Gravis and Anesthesia, the first slide.
Okay. Sharing out going okay? Perfect. So hi, everyone. It's nice to be here tonight. Again, my name is Evan Glidewell. As Sarah said, I'm an assistant professor of anesthesiology at the University of Kansas. I got invited here tonight by Allison. Allison was actually a patient I helped take care of at KU several months prior. She said it was fine if we talked about her experience. And she had given me her business card, and we got in contact afterwards, and she asked if I wouldn't mind coming and giving just a short talk to you guys tonight. So that's how we got here. I am originally from Olathe, Kansas. I completed my undergraduate in medical school at the University of Kansas, and then I completed a residency in anesthesiology at Wake Forest University, which is in Winston-Salem, North Carolina. I finished that in the summer of 2023. So the first job I've had is where I currently am, where I've been for almost 18 months now. When I say that I'm a general anesthesiologist, that means that I don't have a particular specialty. Things that people may think of as specialties are things like cardiac anesthesia. So for patients who are having things like bypass surgery, those are usually anesthesiologists who've done an extra year of training, particularly if it's being done at a major academic center like KU or St. Luke's or any of the other big hospitals around in town. So I kind of take care of more, you could say, bread and butter things, but kind of anything that just falls in the scope of general anesthesiology. So at KU, that includes things like orthopedic surgeries, urological surgery, obstetrical anesthesia, plastic surgeries, the list goes on, but things like that. General overview for what I was going to talk about tonight is kind of what the anesthesiologists know about and then care about with myasthenia gravis. A pre-anesthesia checklist that you could kind of go back to, focusing on what things you should expect before surgery, and then common medications you should or shouldn't take, and then other expectations leading up to and then on the day of surgery. Probably the main part would be different explainer of the different types of anesthesia. And how some of them have maybe some considerations that we would think about with myasthenia gravis, and then any specific concerns or recommendations for patients with myasthenia gravis. There is something in the chat. I'm going to check real quick. Okay. What's the concern with myasthenia gravis for anesthesiologists? It's historically actually a disease process that is focused on by the American Board of Anesthesiology. And so because of that, it is frequently tested during residency and our certification exams, both during residency and then again after we finish residency on our national test that we have to take upon graduation, and then the things that we review forever. So your anesthesiologist should be very familiar with implications of anesthesia for myasthenia gravis and common problems with myasthenia gravis. We are certainly not experts like your neurologist and aren't going to have the level of knowledge there and are not going to know about all of the specific medications, specifically, particularly with the newer medications that you may be on. Our big concerns are the concerns for potential for respiratory compromise, either with sedation and anesthesia, or if your intubation is required for general anesthesia, depending on the type of the surgery, potential with difficulty getting off the ventilator and then safely being extubated after surgery, and potentially needing to go to the ICU on a ventilator after surgery, which is almost never the plan for kind of things that we would generally do. An additional concern is for possibly starting a myasthenic crisis, and that could be triggered just with the stress of surgery, the stress of anesthesia, potential for different medications, infection, or many different things that we may run into if you're having surgery and needing anesthesia. Oh my. So there are some known risk factors. That these are things that will actually show up on our tests that I previously mentioned. And these are risk factors that have historically been associated with having an increased likelihood of having a problem with anesthesia and myasthenia gravis. These things that we think of are duration of disease greater than 6 years. If you take an anticholinesterase inhibitor like pyridostigmine, having a daily dose of greater than 750 milligrams, the presence of another chronic lung disease, whether that is respiratory compromise from the myasthenia gravis, things like obstructive sleep apnea, COPD, having a preoperative vital capacity of less than 2.9 liters. Normal is somewhere around 4.5, just for context and kind of putting the 2.9 to a number. Many patients will not have PFTs done prior to surgery, and that's pulmonary function testing. So that's not something we're necessarily going to know, but some patients may have had pulmonary function testing, and that's a number we would compare or could compare to, just kind of to help risk stratify patients. The presence of bulbar symptoms, so things like dysarthria, or difficulty or weak speech or nasal speech, and then blood loss greater than 1 liter intraoperatively, so surgeries that have greater blood loss or potentially require blood transfusions, also put patients having greater risk. When we say known risk factors, the absolute risk for having a problem is still very, very low, likely less than 1%, but greater than someone who doesn't have these problems. I thought it might be kind of helpful just to kind of briefly review the pathophysiology of what's going on in myasthenia gravis and some of the medications we use that's specific to anesthesia that affects these. So some of you may have kind of gone over this with your neurologist and have kind of good understanding of what's going on, but with myasthenia gravis, you end up having autoantibodies against the nicotinic acetylcholine receptor, which is in the neuromuscular junction. If you can see my mouse, I'm on the left side of the screen there over the green thing. And so that is an acetylcholine receptor. It is in the neuromuscular junction, which is where your body sends the action potential, which trigger your muscles to contract. To cause that contraction, there's a depolarization that occurs when acetylcholine binds to this receptor and potassium goes through, which then causes the depolarization of the membrane. With myasthenia gravis, you have autoantibodies that either inactivate or destroy these receptors, which then cause a progressive inability for this depolarization to occur. Two very commonly used medications with anesthesia are succinylcholine and rocuronium. These are both paralytic medications, and so for things like general anesthesia that require intubation, paralytic medications that relax your muscles are often used. Patients who have myasthenia gravis are resistant to succinylcholine because it binds by binding to that receptor. And so they actually need a larger dose of succinylcholine, although the duration of action is not likely to be significantly prolonged. Rocuronium is an even more commonly used neuromuscular blocking drug that works in a different fashion, and it works as a competitive antagonist of these receptors, which means it blocks the acetylcholine from binding. Since there's less of the receptors that need to be blocked, patients with myasthenia gravis are actually very susceptible to rocuronium. And that was potentially more of a problem in the past, but with newer medications that help to reverse how rocuronium works, it's less likely to cause a complication with anesthesia in myasthenia gravis these days, and we'll talk a little bit more about that later. But that's kind of a primer on the most important thing we're worried about with anesthesia in patients who have myasthenia gravis. So what should you expect leading up to surgery? Prior to the day of surgery, likely several weeks before surgery, and depending on where you are having your surgery done, you should most likely expect to have a phone call from a nurse who is going to be a nurse who does specific screening for anesthesia. They'll probably go over your medications with you, a basic medical history, and depending on your answers to those some medical conditions or some medications you're on may trigger them automatically setting up an in-person pre-anesthesia appointment if you're just having surgery at a bigger place like KU. So some of our patients will end up being seen in the pre-anesthesia clinic, and then some will just have the screening phone call from the nurse. If you do end up having a pre-anesthesia appointment, you should expect that you'd be seeing a nurse practitioner or physician assistant who works there all the time. There's likely an anesthesiologist there, but they're overseeing and just answering questions because there's just too many patients going through the clinic every day for the anesthesiologist to specifically see each person themselves. At that point, they again get a full medical history, talk about medications you're on, previous experiences with anesthesia, and they'd also be trying to collect records to put all of your records in a kind of concise place so the anesthesiologist could easily review them on the day of surgery. They're also, one of the main things to do is to make sure there's no additional testing you need prior to your surgery and your anesthesia. What they're trying to do is limit any cancellations that happen on the day of surgery because of testing that could have previously happened. They may or may not know what kind of anesthesia you're going to likely have based on the type of surgery, and they may be able to answer some of the questions about that, but they may not know because they don't generally provide anesthesia themselves. They will go over your medications either on the phone or in person and give you a list of things that you should and shouldn't take on the day of surgery. So medications we do want you to take, we want you to take all of your myasthenic medications. So any type of immunosuppressants, any anticholinesterase like protostigmine, and then any steroid medication if you're on chronic prednisone. If you take your prednisone in the morning, we'd like you to take it that morning. If you take it at night and you don't take it in the morning, it's not something you need to switch your dosing around. But we'd like patients who are on their steroids long term to get them the day of the surgery. And depending on your actual dose of prednisone, you may also need an additional dose of stress dose steroids with the surgery if it's continued for a short period after surgery. If you use any long-term inhalers, I'd like you to use those on the day of surgery. And then if you use albuterol, or if you have albuterol, it's not a bad idea just to bring it with you. They may have you use some of it before actually going back for surgery. Any heartburn medicines, any thyroid replacements, beta blockers like metoprolol, pain medicines that you usually take in the morning, and most antihypertensives are okay to take as well. Medications we'd like you to hold, the one exception to the antihypertensives is ACE inhibitors, so things like lisinopril or anything that ends in a pril, we generally ask patients not to take on the morning of surgery. Pretty much all anesthetic medications universally make people's blood pressure lower, and so it can sometimes become dangerously low, particularly if patients have taken their ACE inhibitors. There are several things we can do to fix that during surgery, but it's something we try to avoid. If you take diuretics like Lasix or a water pill, we generally don't take those. Newer medications, the GLP-1 agonists, so things like Ozempic, currently we ask patients to stop those for 1 week. That is something that's kind of currently being studied, and we don't know the exact right thing to do for that. But there's concern that they can cause something called gastroparesis, which means delayed emptying of food from your stomach, and that patients may have residual gastric material in their stomach, even if they haven't had anything to eat or drink for 8 hours prior to surgery. Excuse me. If you take blood thinners, you'll likely be asked to hold those for a certain number of days, depending on which blood thinner it is. Note, baby aspirin is fine to take, and it's not going to change anything. And then if you're on any oral diabetic medications like metformin, generally don't take those on the day of surgery either. You're going to be asked to not have anything solid to eat for 8 hours prior to surgery. They'll generally say 11 p.m. or midnight. You note that the important thing here is that it's 8 hours. So if you are 100% positive that your surgery is in the afternoon, you could continue eating up until the 8-hour period. Thing is, sometimes things get canceled, things get rescheduled or moved up in the day, and so that can become a problem if you did have something in the morning because you thought you weren't going to have surgery until the afternoon. You can have clear liquids up till 2 hours prior to surgery. Very important note for coffee drinkers like myself, this includes things like black coffee or black tea. You can't put cream in there because that delays how fast food or liquid leaves your stomach and would push it to the 8-hour period. As long as there's no cream, black coffee or tea are fine up to 2 hours before. Other things like carbohydrate drinks, Gatorades, are all okay. And depending on what kind of surgery you're having, there's a lot of push for different surgery protocols where patients are given carbohydrate drinks specifically to drink up until 2 hours before. So you may be given it by your surgeon or at the pre-anesthesia testing appointment. If you use a CPAP or BiPAP type device, either for obstructive sleep apnea or because you have respiratory weakness with sleeping with your myasthenia gravis, we would like you to bring it with you on the day of surgery. Um, it may or may not be used either before, after, or during the procedure, depending on what kind of procedure you're having and what kind of device it is and how much you actually need it. Also note that to have surgery, if you're having outpatient surgery, you'll have to have a responsible adult to drive home and then stay with you on the first night. So what actually happens on the day of surgery if you've never had anesthesia or surgery before? You'll show up to the hospital and check in for surgery. That usually occurs about 2 hours prior to the scheduled surgery start time. So if you're first start in the morning, that may involve getting to the hospital around 5 a.m. or so. You'll have a pre-op nurse who will get you checked in, changed into a hospital gown. They'll again go over what medications you've taken, take your vitals, and they'll have to start an IV. Excuse me. You'll meet with an anesthesiologist and they'll go over your medical history and then plan for anesthesia at that point. And so that'll be your opportunity to, talk in depth about your myasthenia gravis, any other medical conditions you need to talk about, and then ask them questions about what kind of anesthesia you're going to have. If there's alternatives, things they're worried about, anything along those lines. You'll meet any other parts of the anesthesia team, whether that's a certified registered nurse anesthetist, a resident, or anyone else who may be involved. What do anesthesiologists want to know about your myasthenia gravis? We would like to know what myasthenic medications you take, if you take steroids, how long you've been on them, or if you took steroids in the past and when you stopped them. Any history of bulbar symptoms or respiratory symptoms with your myasthenia gravis, and what other symptoms you notice and at what point of the day during you notice them. So bulbar symptoms, we're talking about things like dysphagia or difficulty swallowing, dysarthria, nasal speech, or a weak voice. The specific concern with those is that it could put patients at risk for aspiration if they have weakness of their oropharynx. Any history of complications related to anesthesia or family history of any problems with anesthesia, histories of any myasthenic crisis, or and particularly if it required you being intubated or needing invasive ventilation or non-invasive ventilation for that matter. And if your neurologist has any recommendations for you with having anesthesia. Note, if your neurologist is at the same place you're having the anesthesia, the anesthesiologist and the surgeon for that matter should be able to see the neurologist note and if there's any recommendations. If your neurologist is somewhere else, it's kind of just 50-50 whether we're able to see that in the electronic medical record, excuse me. At this point, I was going to briefly go over different types of anesthesia, kind of what they are. These are the specific terms for them, but there's other things lay people who don't do anesthesia may call them, what kind of expectations you should have with them, and what the recovery and benefits and cons to each of them are. So general anesthesia. When we say general anesthesia, that means more or less complete anesthesia. In adults, it is almost exclusively started with a combination of medicines given via the IV that produce complete loss of consciousness at that point. It is then generally maintained with breathing of anesthetic gases. And so those are things like sevoflurane. They're related to halothane if you've seen that in movies or TV shows, although there's newer ones that are used other than halothane. Although the anesthetic gas part is not 100% true. There are sometimes situations where that's done differently. It may or may not require the use of a paralytic medication, like I talked about earlier, which does have the implications of the myasthenia gravis. Most of the time with general anesthesia, an endotracheal tube or a breathing tube is placed. So that is a small plastic tube that goes down into your trachea, into your windpipe. And then there's a ventilator that the patient is hooked up to that you breathe the anesthetic gases through during surgery. There's also something called the laryngeal mask airway, which is a slightly less invasive type of breathing device. It's a mask that sits in the back of your throat, but doesn't go all the way down into your windpipe. General anesthesia is required for most intra-abdominal surgeries, intrathoracic surgeries, things like thymectomies, neurosurgery, different type of ear, nose, and throat surgeries, thyroid surgeries. There's many, many things that's very commonly used, and it's very safely performed now. There is monitored anesthesia care. This is sometimes referred to as MAC, just the acronym. This is what we mean by this is IV sedation. There's a wide range of levels of sedation that can be used, but it most commonly means a propofol infusion to the point where the patient is still breathing on their own, but are otherwise then kind of under twilight anesthesia, kind of like a deep sleep or nap at home. Because they're breathing on their own, they don't require intubation or having an LMA placed, the less invasive type of breathing device. Um, However, sometimes patients who need a CPAP may need it during the procedure to tolerate this safely or some type of other pressurized oxygen delivery, just like they do when they're asleep at home. We will always tell patients when they're going to have monitored anesthesia care that we can't guarantee that they're not going to have some type of memory that gets formed. The vast majority of patients don't have any memory, but occasionally it's like twilight sleep at home. People may have some type of vivid dream, or more commonly remember someone saying their name at some point during the procedure. There's always an anesthesia provider sitting there with them. So if the patient starts to move during a stimulating part of the procedure, as long as all of their vitals and their breathing is safe, they just get more of the sleepy medication than they were getting, although it's going the whole time. If patients do form some type of memory, it's usually not something that's concerning. They may say afterwards, I just, briefly remember opening my eyes, or I briefly remember someone saying my name and I didn't know what was going on, but that was the end of it. So often when patients say they woke up during a colonoscopy, this is the type of anesthesia they were having. And so it wasn't really out of the range of expectations that happened. The most common place this is used is in GI lab procedures, so things like colonoscopies or upper endoscopies, but it can sometimes be used for other procedures as well. Allison said it was okay that I shared this with you. When I helped take care of her, she had a level of monitored anesthesia care. For her, we were able to use her Astral non-invasive ventilator during the procedure. That was something we had a long discussion about. I had concern that she would need some type of positive pressure just with her non-invasive ventilator, like she does when she's at home, to tolerate the anesthesia. And she had her not astral ventilator with her that day. And so because of that, we were able to use it instead of needing to do things like a breathing tube. That was something that we talked about, and we kind of went through all of the options. And so we were comfortable using her astral ventilator that day. And it's not necessarily something that all hospitals or anesthesiologists would be comfortable with, but it was a good option for her that day, and it worked very well. And we were all happy with how it went. Everything was safe and nice, good anesthesia. A different type of anesthesia is regional anesthesia. And so this may be something that would be suggested for a patient with myasthenia gravis. It is a nerve block on a whole extremity, so an arm or a leg. We accomplish that with the aid of an ultrasound, so we can see where the nerves are coming out of the neck into the arm, or going in from the hips into the legs. And we put numbing medicine similar to lidocaine around those nerves to make arms or legs numb. It can also be done just with lidocaine injected around a surgical site if you were having a small skin surgery or something along those lines, a skin cancer cutoff. And the goal is to completely numb the surgical area. So with that complete numbing, we don't take away the sensation of pressure, but patients shouldn't feel anything sharp, have anything actually painful happen. Because they are completely numb, they don't necessarily need any anesthesia in the IV, although most of the time this is combined with monitored anesthesia care to do propofol sedation for patients in addition to having the nerve block. Depending on what type of nerve block you have, it may last for just a few hours, or if they use longer acting medications, it could last for up to 24 hours, depending on what's injected. Because of that, sometimes it's done just as an adjunct to help with pain after surgery. And then sometimes it's done as what we could say the primary anesthetic, meaning it was the thing keeping the patient comfortable during anesthesia and not general anesthesia. A similar option would be neuraxial anesthesia. So that means a spinal injection. Again, that's accomplished with injection of lidocaine, similar medications into the fluid at the bottom of the spinal cord. So that would be very similar to a spinal tap, or into the epidural space. And the epidural space is the area one layer over from the spinal cord, where we inject the numbing medication in there, where it then bathes the nerve roots in that area to produce numbness. And this is something that is, I think, generally very scary for patients, because it's not something they've experienced before, and you just see things in movies or wherever, but it's generally very well tolerated. We use a little bit of numbing medicine in the skin, and so that's kind of like a bee sting for 5 to 10 seconds. And generally after that, there's really only a small amount of pressure and not sharp pain or anything else uncomfortable from the actual procedure itself. And in most patients, it happens very quickly. It does not take long to do the procedure at all. Again, this is so patients then are often concerned that they're going to be awake if this is done. But again, this is usually combined with the propofol sedation or monitored anesthesia care, and that's just for patient comfort. The most common thing this would be used for would be knee and hip replacements, although other types of lower extremity orthopedic surgeries or any other surgery on the lower extremity may be appropriate for this as well. So what happens immediately after surgery? So depending on the type of anesthesia you have, if you have general anesthesia, the plan is to take the breathing tube out in the operating room. So we turn off those gases that patients breathe, and as those gases are going away, patients start to wake up. We wait for them to show different signs that it's safe to take the breathing tube out, but then kind of right as they're waking up, that breathing tube comes out. Say probably greater than 95% of the time, patients don't have any memory of any part of that process until they get to the recovery room. Occasionally, they might remember saying they just remember coughing and gagging for a second, and then kind of next thing they do remembers and they're in the recovery room. So they're not necessarily fully awake and having any kind of unpleasant experience as that breathing tube is being taken out. Again, most patients, the next thing they remember after surgery is that they're starting to wake up in the recovery room. In the recovery room, you're with a PACU nurse, and that's the post-operative recovery unit. And that PACU nurse is actually, it counts as an ICU level of care. So you have very, very close watchful eyes, and they have at maximum 2 patients. And they're sitting there with you until you're ready to discharge from PACU. Things that we consider for readiness for discharge for PACU is that you're fully awake, you have appropriate vitals, and any pain and nausea is controlled. It's safe for you to leave. So then from the postoperative recovery unit, you either go to the hospital room if you're going there for the night or for a couple nights, or you'd go home for that point. Specific anesthetic considerations that I think it's important to know about for patients with myasthenia gravis. So one of the concerns is that there's lots of medications, so things like benzodiazepines that are commonly used prior to starting anesthesia. Those are things like IV forms of Xanax that everyone's heard of. And patients with myasthenia gravis can be very sensitive to those medications and can have the risk of oversedation and having respiratory problems from oversedation, kind of if standard doses of medications are used. For that reason, they may try to avoid administering those medications, or they give a smaller dose that might have a smaller effect than in a patient who doesn't have myasthenia. If they talk to you about having a nerve block, if you're having surgery on your arm or shoulder, some of the nerve blocks that we do will result in temporary paralysis of the diaphragm on the same side as the nerve block is done. In most patients, this is very well tolerated and they don't notice anything at all. In a patient with myasthenia, if they have any respiratory compromise, that may produce dyspnea or feeling of shortness of breath that might require supplemental oxygen. Not all nerve blocks on the arm do that, and so it would be most likely a good idea to avoid the ones that do, but it's the consideration in any patients who have any degree of respiratory problems or or myasthenia. I mentioned the use of paralytic medications earlier. It's generally required for surgeries with general anesthesia that need a breathing tube. In the past, this was not quite as safe as it is now. The way that these medications were reversed, meaning so there wasn't any paralytic anymore, was actually very similar to pyridostigmine, and that could cause some problems. There's a newer medication called Sugamidex, which inactivates the paralytics in a different way and is more reliable in fully inactivating those medications. And it makes it much less likely for there to be any kind of residual paralytic on board after anesthesia. Again, when we say residual paralytic, that sounds very scary. That's a very small percentage in patients that does happen to, and something that they can't notice. But in a patient who had respiratory compromise to some chronic degree, that would be something we'd be worried about and more in tune trying to avoid. But the presence of that newer medication, Sugamidex, makes that much less likely. So general recommendations for having anesthesia for patients with myasthenia gravis, depending on the type of surgery, if possible, attempt to avoid general anesthesia to avoid any problems with any of those paralytic medications, even though that's unlikely. And if appropriate, utilize regional, meaning nerve blocks, local, or neuraxial anesthesia, although there's many times where that's not possible, and that's okay. We may attempt to avoid any type of preoperative sedation. So things like not having IV Xanax prior to surgery, just to kind of make sure you're fully awake and kind of recovered appropriately afterwards and safe before. And then also, we'll attempt to avoid medications that are known to exacerbate myasthenia gravis. I didn't put a list in here. That is certainly a list that we are able to look up, but I think it's a good idea for patients to kind of mention it to the anesthesiologist on the day of surgery, because that's not something that's at the forefront of our minds, and it's certainly not something, a list that we have memorized. So if you have a list from your neurologist of anything, you're welcome to bring that, or just kind of happy good for you to remind us, hey, there's some antibiotics that I might not do as well with as other patients, and so I just kind of want you to be mindful of that. And then we've reached the obligatory dog post. So these are my 3 black lab mutts, which some of which have been barking during while I've been talking. So hopefully you haven't heard that. And then I am happy to take any questions that anyone has.
I see that there are a few questions in the Q&A. Would you like
Okay,
me to read them off?
let me see if I can find them.
Okay.
Ooh, great. Yes. So I can see the questions. So I see there's a question. I will go from the top. Any alteration in infusion schedules for things like Solaris, Vigart, etc. So I don't even off the top of my head, I would have to look up other names for those medications, which probably tells you about how well I can answer it. Questions like that, I would encourage patients to discuss with their neurologist. They're much more educated and well read about those specific medications, things like IVIG. They are the experts in, so we would defer to them in general about anything like that. And again, by the time we've met you on the day of surgery, it's too late for us to alter the schedule of those medications anyway. And so anything that would have been changed would have needed to happen before. Is it routine to use Decadron along with an antiemetic during anesthesia? It is very routine. At this point, it's given with almost 100% of general anesthesia. If you have general anesthesia, it's specifically the inhaled gases that tend to make people nauseous, most commonly young women, although it can happen to anyone. It's just somewhat of a genetic thing. So it tends to happen to the same patient if it's happened to them in the past. And Decadron and both Zofran or Ondansetron are given with almost 100% of general anesthesia. If you are on a stress or a higher dose of prednisone chronically, you may also get an additional steroid, but that would be a more case-by-case basis. It says, I'm allergic to all anti-nausea meds. Advice? This is a tough situation. It happens to some patients. Without talking to you specifically about what things have happened and what medications you've had, it's hard to answer specifically. There is certainly an option to do only propofol, which can be done for general anesthesia. It just takes a couple extra steps. It's not appropriate 100% of the time, but can often be done safely. And propofol itself does not tend not to make people nauseous and actually considered an anti-nausea medicine itself. Um, Even if you don't get anesthetic gases, there are still patients who get nauseous after surgery. Just the surgery itself can make people nauseous, or the pain medicine certainly can make people nauseous. So that's a tricky situation. And there's also some newer anti-nausea medications coming out as well, which you may not have had before, which might be an option. Are there any anesthesia needs or concerns for patients getting epidural steroid injections as a treatment for lumbar pain, stenosis, or bulging discs? CPAP necessary? Not generally. I do not any longer do epidural steroid injections in that manner. Those are generally people who have done a pain fellowship who that's kind of their full-time job rather than taking care of patients in the operating room. But for the most part, you don't get any sedation during those type of procedures. So having things like a CPAP wouldn't be necessary, and there wouldn't really be any concerns. 10 years prior to my diagnosis of myasthenia gravis, I had breast cancer in 2008. During my third biopsy, I woke up on a respirator. Of course, I'm always worried when going under anesthesia. I did have my thymus removed. Anesthesia was okay, even though I had a bad crisis after. Just just a comment on that one. I'm glad it's gone better for you recently. So that is kind of bringing up a concern there. And so the ultimate concern for any patient with respiratory compromise of any type or myasthenia is the potential for needing the ventilator after surgery. When that happens, we do give medications to keep you comfortable while you're on the ventilator. So people shouldn't be worried about um, kind of discomfort during that period, but of course worried about your safety and being able to breathe safely. Scott says, what about acupuncture? If this is in reference to postoperative nausea and vomiting, there is some suggestions that there is acupuncture at a specific spot in the wrist that is helpful with that. It's not anything that I know how to do. It's not anything I know for my partners knowing how to do, but potentially would be an option either before or after surgery. What foods might you avoid and what foods are better following surgery? For the most part, the instructions we give to patients are they can have anything that they feel they can tolerate. So some patients are, very prone to nausea after surgery, and they have to take things pretty simple, maybe just with liquids for the day or things like that. Other patients can kind of resume a normal diet and they don't have any problems. Depending on the specific surgery you have, your surgeon may or may not give you limitations about what you're able to eat if you're having abdominal surgery or gut surgery. But otherwise, you can have whatever you like. It is possible to get a copy of your slides. They are recording them, so you guys should be able to see them later. Scott has also asked, what about IV magnesium? That is not commonly used during surgery, although it is sometimes used either as actually an adjunct for pain medicine. And there may be some data that it's helpful with postoperative nausea and vomiting, but it's fairly rare for that to be used during surgery. I'm scheduled for cataract surgery and take about 540 milligrams of prostaglandin. So just the advice would be to take your medications like we talked about on the day of surgery. And then what you should expect is that they're going to do a pretty light level of monitored anesthesia care. And so you may just get just a little bit of sedation and then some type of eye block from the ophthalmologist, although that could change on the day of surgery. On the other side, someone has posted, is there any indication for myasthenia gravis in general? Peripheral block anesthesia can cause a drop of blood pressure during surgery or 6 to 8 hours post-op. It's happened twice in 3 months. One general umbilical hernia repair with propofol inhalational anesthetic, tap blocks. So what I would say about the second part, and it said the second was a shoulder replacement, and they had propofol only and a nerve block done in their shoulder, and that required a neosynephrine drip, which is a medication called phenylephrine. So again, what I mentioned earlier with blood pressure and not taking blood pressure medicines on the morning of surgery, propofol and pretty much every other medicine we give, it's very common to have some blood pressure drop. Sometimes patients require things like a phenylephrine drip during surgery, and if that's all that was required, I would kind of consider that standard anesthesia. It's almost 50-50 sometimes in terms of patients who need that, particularly for surgery of the shoulder because you end up sitting up. And so kind of just because of your head up position, you need additional help for vasopressor medications like phenylephrine. And so that would really be pretty standard, and I wouldn't consider that unusual. Certainly the first question here with having to go to the ICU and needing Leofed or norepinephrine would be unusual. Again, some blood pressure drop is normal with the anesthesia, but that sounds like there was something else happening, and I'm not sure that there's any association with myasthenia gravis that I know of that might have caused that. Sarah, do you see any other questions that I didn't get to?
Compazine allergies.
I think that was about the question with all
Okay.
nausea. Again, so that's a difficult situation. I've certainly met many patients like that, but hard to give a specific recommendation there, but just something to talk about with your anesthesiologist on your day of surgery. Something else popped up. So metoprolol is used to control pulse rate. So metoprolol is considered a beta blocker, and it's actually a strong recommendation that we want you to take that on your day of surgery if you're on it long term, or if you're on it at all. So continue your beta blockers if you take those on the morning of surgery.
Thank you so much. Any other questions anyone has? Feel free to drop them in the Q&A now. All right. Thank you
Well,
so much, Dr. Glidewell. We appreciate you.
sure. Thanks for
Time.
everyone for coming and listening, and hopefully you were able to learn something. So.
Anything
Yes,
else, Catherine, that we may have missed?
Nope, you are all good. Thank you guys. Have a great night.
Take good care.